on the left side. So this is again a patient that's suffering with back pain and left leg pain. Her back pain is higher up in the lumbar, not at the typical L4-5, L5-S1. It's actually at L3-4. And we know from, good morning, from the MRI that the pain radiates into the left leg. So this is again Dr. Ara Deuk, CEO and founder of Deuk Spine Institute, Surgery Center of Viera. What is the date today?
23rd?
April 23rd, 2019. All right, got a lot on my mind, you can tell. One thing on my mind is the fact that the men's bathroom is about to get very dark. The lights are all burned out except one, and there's only one fixture. So this is your facility now. Okay? Este es su barrio. Okay, treat it like your home. Everything. Look around and, you know, make sure it's the way you would want it for your family or your guests. That's what Carl used to do and does, but now that torch is being passed to you, okay? So always look around and see what needs to be fixed. Huh? My eye? What's wrong with my eye? Oh, serious? The right one? I think it's my contact. It's just a little too tight on my eyeball. All right. Good morning. Dr. Deuk here. Can you hear me okay? Zach, can you hear me okay?
Yes, sir.
All right. So we're going to get started, okay? It's important that you don't move. Just lay still. If you feel pain, just say ouch, and I'll give you some more medicine, all right? But don't be moving your body around. Are you comfortable right now? You want to move a little bit to get more comfortable, or are you okay? Good? All right, we're going to put you to sleep soon, but not just yet. All right, you're going to feel a little stick and burn, okay? That's just the medicine going in. That's my finger pinching you. A little stick and burn, all that's normal. Okay, this is normal, what you're feeling, so we're just giving you some numbing medicine. So we're numbing up her skin so we can go ahead and place our needle in. The needle will be used to create a path from the outside world to her disc at the level of the herniation. We're on the left side. Everybody's in agreement?
Yes, sir.
Now, what am I going to need to see? Nope. What do I need? Yeah, I do need to see an AP. Oh, so you have it in AP. I need on the lateral, I need to see the sacrum. All right. So that MRI is up. Boy, it's a little dim. There we go. That's better. 5, 4, 3, 3, 4 has the big herniation. You might feel a little discomfort. Just say ouch, okay? So this technique, for those of you watching, was developed to avoid having to go posterior translaminar. All right, lateral, please. And what that means is all these other spine surgeons around the world, they all come through the back. They go in the middle, which is this area here. And when they get to the spine, the first thing they do is start drilling bone away. They make a hole in the spine. They make a hole in the bone. And part of that hole is actually right where the facet joint is. 5, 4, 3, 3, 4. We're doing 3, 4, correct?
Yes, sir.
Everybody's in agreement? Yeah, the facet joint is very important to stabilize the spine. Sean? That's it? That's interesting. Yep. Shot. Huh? Needle down? What is it, Carl? Yeah, where's my local? Still sterile? So the purpose of these surgical video broadcasts are really to teach the world about state-of-the-art spine care that's available, and to educate the public and educate other doctors on what can be done, because many people don't even know these techniques exist. And just like many people around the world don't even know that there's a International Space Station, right? Shot? But there is an International Space Station. And it's extremely sophisticated and advanced. But people wouldn't know about it unless you show them the International Space Station. Shot? Are you comfortable? Yes. And so, Shot, our job is to show people what exists. AP, I think she's a little rotated. You could see on the lateral view, the back of L3 is a little rotated, but still we're pretty far away. Alright, so we're just too posterior. Let's go back to, let's see. Let me see what I can do here. Shot? It's better. Lateral. Nice, you did a good job on the EP, by the way, lining everything up. Shot. 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 AP. So I would just say that her spine is pretty far anterior. Right, Dr. Santiago? Isn't that a good way to describe it?
That's a good way to describe it.
It's very far anterior from the back. All right, lateral. So these surgeries that you're watching, if you're watching today, it's broadcast live and without editing. So you're watching a live spine surgery, non-edited. And of course, without the editing, you're going to get everything that we're getting in the operating room live. Shot? Are you comfortable?
Yes.
Let me know if you feel any pain at all. Are you comfortable still? Yes?
Yes.
All right. I can feel the herniation, as a matter of fact, very easily. I could feel it in the foramen. There was a herniated disc, and I went through it, and I could feel it with the tip of the needle. Give me an AP, please.
We have a question.
Yeah, I'll take the question in just a moment. So for those of you watching the surgery, the Deuk laser disc repair is the name of the surgery. It was pioneered and developed here at Duke Spine Institute. Good. Thank you. And the surgery, go ahead and go lateral. Actually, you could, you can stay AP. The surgery was developed to avoid having to remove any of the bone from the spine, and to avoid big incisions and muscle damage, which you typically will get with normal surgery, translaminar surgery, meaning going through the back. It's what most every other surgeon in the world does. But the transforaminal approach was developed by Parvis Camben in the United States. Are you comfortable? So she's comfortable. How bad is that on a scale of 1 to 10? What was the highest? I don't know if you heard her, but she went, oh, and she tensed up. How bad was it? How high did the pain go? What was the highest it went? 9. All right, so 9 out of 10. Was that where your typical pain is? Is that where you more so the location is more important rather than the quantity. So what we did was a discogram, folks, just to confirm that the L34 was the cause of her pain, and indeed she jumped off the bed. She had 9 out of 10 pain, and we confirmed that indeed the L34 disc is the source of her pain. You can see the dye that I injected is radio opaque, so you can see some of it in the disc, that dark stuff where the needle is, and then it came out through the tear in the back, and you can see it in the epidural space behind the L4 vertebral body. I can't really point to you, but that's the dark material that's there now that wasn't there before. So it's around the nerve root. So clearly the tear in the back of the disc is allowing material to leak out around the nerve root. As you can see, the dye is highlighting that. So the discogram is a very important step, and it's an intraoperative evocative discogram with the patient awake. Is she asleep now? As soon as we do the discogram, we can then put the patient to sleep, once we've done all the needle placements and the discogram. She sleeping? Have you given her happy juice? All right. Do I need to have her count, or are you going to do that? We're going to make our incision. Remember, we numbed the skin up earlier with the Novocaine, and we'll take the question now, Zach. Make a small incision, 7 millimeters.
We have a viewer asking, if you fix an annular tear, what is the likelihood of it reoccurring while bending with spondylolisthesis at L2, L3, and L4?
All right, so the viewer is saying if you do the Deuk Laserdisc repair and you fix an annular tear at L2, 3, 3, 4, what's the chance that it will recur if they have spondylolisthesis and something about bending? So the answer is, in general, when we fix the annular tear, there's no recurrence. The only way you're going to get a recurrent herniation is if you break the rules. And those rules are no bending at the waist for the first 6 weeks to pick things up from the ground, and no lifting heavy items over 25 pounds for the first 6 weeks. So as long as you follow those restrictions, the chance of reherniating is 0. I've never had anybody just reherniate without doing something they're not supposed to do. Now there are patients who just do a little too much, afterwards, after surgery, because they're feeling so good. We see it quite often, actually. The patients are feeling really, really good within a few days or a week of surgery. Their pain is gone. They're so happy that they're out there doing all kinds of stuff they shouldn't be doing. And again, as long as they adhere to the restrictions, and the restrictions are simple. There are no bending at the waist in any form or manner, and no lifting over 25 pounds for the first 6 weeks. Once we get to 6 weeks, they can go up to 40 pounds, shot. So right now I'm advancing the dilator. So I'm not going through bone. The bone is in the back here. We're going around the bone. There's a natural hole in the spine like this. It's called the neuroforamen, and that's where we're going. It's a natural opening in the spine. There's no bone there. We're just going right through that foramen. And again, I did not develop the transforaminal technique. It was developed by a doctor named Parvis Camben in Pittsburgh. Shot? Is that it? So that was a long time ago that Dr. Camben developed this technique. And he taught it to some doctors, some surgeons, and it was passed down over the years. And I learned it not from him directly, but from other surgeons that learned it from him. I learned this technique from the Koreans, from the Germans, and from an American surgeon here in the States, Dr. Tony Young, over in Phoenix, Arizona. So I took what these other surgeons knew about this approach and I modified it to do it differently, which I thought was a better way, and it turned out, in my opinion, it is better. And the reason I say that is my results are better. And what I mean by results, I mean my success rate is 92.5% relief of back pain from the discs, preoperative back pain, and 92.5% relief of leg pain. So that's higher than them. That's average, by the way, for all patients. And let's go AP. Just want to make sure this is not trapped. And then, of course, we've had 0 complications with our patients' surgeries in 13 years. So we've never had a complication. Go back to, that's pretty good. Let's go back to a lateral. So 0 complications in 900 surgeries and a success rate of eliminating back pain of 92.5%. Shot? I think that should be good. So we want to be inside the disc when we start. Now this technique was developed by Dr. Young. He calls it an inside-out technique where you start inside the disc. He taught it to me. There are other surgeons that start in the foramen and then work their way into the disc. I think that's much more dangerous for the patient, and it's more complicated, and there's a lot more blood involved, so it's riskier. So I think the inside-out technique developed by Dr. Anthony Young is probably the best technique there is. I've tried both ways, and I think the inside-out is better. Now you can see from the x-ray picture that the tubular retractor that I'm going to do the whole surgery through, which is about 7 millimeters, is actually inside the disc. And that's the L34 disc. Everybody agree? Dr. Santiago? Yeah. You can see the sacrum down low. Why don't we go ahead and get one more lateral? Let's turn the scope off. Let's get one more lateral just to confirm 100%. I already know it's 3-4, but let's just verify that. Do we have another question, Zach? All right. I'm not sure if Zach is away from keyboard.
Sorry, I'm just reading through them.
Table up or fluoro down.
We do have a question.
Yeah.
We have a viewer asking, how do we get invitations to Carl's boat?
Ah, all right. So you want to crew for Carl. Very good. So as most of you know by now, Carl Taylor, who's been with us for several years, is leaving to sail around the world for several years. So he will not be part of normal civilization. Yeah, that's good. So we got sacrum 5-4, 3-3-4. And somebody wants to join him. I don't blame you. Carl, I'm sure, is an excellent captain, right?
Yes.
So they're wondering, how do they get on your boat, Carl?
They don't have a captain's license. They would have to crew. So it's not a vacation.
He's saying that he doesn't have a captain's license, and that if you want to come on the boat, you've got to make yourself useful. AKA, you've got to be helpful with crewing, which I'm sure you're willing to do. Just come by the surgery center and have a chat with Carl. He'll talk to you about it. He said no freeloaders, though. All right, we're inside the disc, and the first thing we're seeing is that you can see the annular tear. So see the white fibers right there? Yeah, right there and right there. You see how there's a tear between them and there's blue stuff in there? All right, that is the actual annular tear. It starts in the center and works its way out, all the way out to the periphery. So that's what I have to debride with the laser. And I said before in surgery that Deuk laser disc repair is the first surgery in the world, and currently the only surgery in the world that I'm aware of that does an annular debridement. Certainly we were the first to publish it in the National Library of Medicine, thank you, in Surgical Neurology International, which was the journal we published in 2012. So you can see I'm cleaning up the annulus, debriding it, we call it, where you clean away the torn edges. You basically remove this tissue. And the reason we're doing this is the annulus has been trying to heal for a long time in this patient. So they had the tear, they had inflammation. Inflammation is your body's attempt to heal a wound, whether it's a broken bone or an incision in the skin or anything. The first step of healing in the human body and all animal bodies is an inflammatory response or inflammation. So, the inflammation came in, the body tried to heal the annular tear, and it was unsuccessful. And I believe it was unsuccessful because that there was a large piece of nucleus pulposus wedged in there. And that would be the herniation we're talking about. So the jelly from the center of the disc squeezed out through the tear, and it just sat there inside the tear. And the edges of the annulus at the tear want to heal and close back together and rejoin in the middle, but they can't because there's a piece of this blue disc just wedged in there, keeping that from happening. All right, one of the other things that this technique allows us to do, I think is very important in the inside-out technique, is when you introduce the dilator through the annular tear, you actually push the herniation back into the disc. Stand by laser. And what that does is it allows me to remove the herniation from inside the disc rather than outside the disc in the foramen, which is always safer because what's in the foramen? Nerve roots and blood vessels. So whenever you can avoid operating around nerve roots and blood vessels, it's always safer. Thanks.
We have a question.
There's the tear right there. Yes. Let's bring the brightness down one click.
We have a viewer who says, I have a slip disc at L1, L2, and L5, S1. Would you be able to do both of them in the same laser surgery?
Yes, so somebody says I've got 2 disc herniations in my lumbar, but they're not next to each other, they're far apart. Would you be able to treat both of them in one surgery? The answer is yes, easily. We can treat up to 4 areas. And what I mean by that is you can have 2 disc herniations that are affecting both legs, left and right. We can go on both sides of 2 disc herniations. So that's 1, 2, 3, 4. When you go on both sides, we call it bilateral. So that would be bilateral at one herniated disc because you have bilateral leg symptoms, and we can go bilateral at the other herniated disc. So that's a total of 4 points. Or we can do, if you just have one-sided leg symptoms, we could do 4 herniations, up to 4 herniated discs on one side. So again, 4 points. So this is all the annular tear right here, chronically inflamed. This is the source of the patient's back pain, what I'm cleaning up right now. And because there's a large tear in the annulus, it literally, the end of the tear is right where the nerve root is. I'm going to show that to you at the end. So the problem is that the tear every day, all the time, is under inflammation, and it's leaking the inflammatory juices right out onto the nerve root, which then causes the nerve root to be inflamed. And we call that a radiculitis. And that's really what causes leg pain. Sciatica is a radiculitis, inflammation of the root. And then, of course, there's a compressive component in some people where they actually have compression of the nerve root. But the biggest myth we need to get rid of and just eliminate is that to have leg pain or sciatica, stand by laser, the patient has to have a big herniation up against the nerve. You don't. About 95% of the time, our patients have leg pain, but they don't have a big herniation. They have a small herniation. And it's really not compressing the nerve root on MRI. So it throws off most surgeons and doctors. They say, oh, that can't be the problem because it's too small. Well, it is the problem, and it's not a compression phenomenon, it's a chemical irritation phenomenon. And that's one of the reasons why medicine is so far behind in reality, is because these surgeons are being trained to believe that it's the size of the herniation that matters and not the chemical nature of the herniation that matters. But it's the chemical nature of the herniation that causes the back pain or neck pain and arm or leg pain. That's what most people have. So it's confusing to most doctors. Well, look at that herniation come back out. It's confusing to most doctors because they don't understand the inflammatory component of a herniated disc. They weren't trained on it. They don't understand it. There wasn't any literature on it or teaching on it. Standby laser. How are we doing on irrigation? They don't have any knowledge of it. And so because they don't understand it, they don't know about it, they can't treat it, they can't act on it, right? Things we don't know about, we can't fix. You have to know about a problem in order to be able to fix it. I became aware of the inflammatory nature of herniated discs after I got out of residency in neurosurgery, because I started to talk to the pain management doctors. You see, pain management is a whole nother specialty. And these interventional pain management doctors that do epidural steroid injections for sciatic pain, radicular pain, or back pain, I saw that those patients did well. And I'm thinking to myself, well, they didn't decompress the nerve root. They just injected an anti-inflammatory medicine. Why is it working? And it works because most pain that people get in their back and leg or neck and arm from a herniated disc is due to inflammation. It's not due to compression. So this is where I differ from my colleagues. They all think about spine disease as being a compressive problem, but it's not. It's actually a chemical irritation inflammatory problem. So once you understand that fact, you can act on it. But until you understand it, you won't act on it. Which is why most neurosurgeons and orthopedic spine surgeons, they don't treat the pain because they don't see a giant herniated disc associated with it. So they don't treat it. They leave it alone, tell patients to go do physiotherapy. The problem is all the physiotherapy in the world isn't going to make a difference in their pain. They've already tried physiotherapy, it won't work. Their body just can't heal the tear, so they need help. And that's why I developed the Deuk laser disc repair, was to go in endoscopically and repair and debride the annular tear to get rid of their back and neck pain and arm and leg pain. Even Dr. Young, Anthony Young, who I learned a lot of the technique from, he does surgery for decompression, to go in and remove the herniation that's pinching a nerve. He only does lumbar, by the way. I had to develop the cervical by myself for the most part. I learned the basics from the Koreans in South Korea and Germany, but once I learned the basics of the approach, I ended up developing the cervical technique pretty much on my own. Standby laser, because there's nobody else in the United States that does anterior cervical endoscopic surgery except Dr. Joe, and he does a through the bone approach, which I don't do. I do a transdiscal approach. He does a transvertebral approach. Long story short, he and I are the only ones that do anterior cervical endoscopic surgery in the cervical spine, but we do very, very different techniques. Ready. So we're almost done with this herniation. Probably 5 minutes left, Dr. Santiago. I start seeing some of the fibers of the posterior longitudinal ligament here. The red stuff that you're seeing is blood. It's clouding up things a little bit, but fortunately I have a fair amount of experience doing this procedure, so I can see through the blood cells, so to speak. This part of the herniation here is calcified, and that means it's been there for a long, long time. Usually on the order of years, at least 3, 4, 5 years. There are some telltale signs that this has been going on for a while. That's a bone spur. Zach, we have any other questions?
We do actually. We have a viewer says, if inflammation causes pain, wouldn't a cortisone shot make the pain worse from all the pressure?
Alright, so somebody says if inflammation causes pain, wouldn't a cortisone shot make the pain worse? Well, obviously, those of you who don't know what cortisone is an anti-inflammatory. It's a very powerful anti-inflammatory called a steroid. It's a steroid anti-inflammatory, and actually they would make the pain better. But I assume you're talking about a hydrostatic as you're injecting. Steroid injections are typically painful when they're injected, so that would support that the pressure of the injection would cause some discomfort. But that's very temporary, just a few seconds, and it's gone. So, unless I misunderstand your question, the answer is no. A cortisone shot could make it better. Doesn't always make it better, because remember, you have to be able to access the area of inflammation. And cortisone shots are where the doctor injects near the area of inflammation in the epidural space. Standby laser? They don't actually inject into the inflammation. They inject near the inflammation. So that may be why they don't always work, is because you're not injecting directly into the inflammation. The inflammation is in the annular tear. You're not injecting in the annular tear when you do an epidural. The inflammation is on the nerve root, but the nerve root is being scarred. I think we're just about done here. I just need maybe another 30 seconds and we should be done. I'm going to go ahead and go through this ligament because I want to make sure we get all the herniation we can. So if the person who asked the cortisone injection question has additional questions, I can take them now if you can type fast enough, or I can take them in the mission control when I come over there. What other questions do we have, Zach?
Gone through them all for now.
All right. So again, I'm Dr. R. Deuk Magin, founder and CEO of Deuk Spine Institute. We're here at Deuk Spine Institute, Surgery Center of Viera, performing a Deuk laser disc repair. Our patient is comfortably asleep with Propofol Sedation. Dr. Santiago is monitoring her very carefully with her breathing and her blood pressure and her vitals, as well as maintaining her Propofol sedation. We use Propofol for these procedures. The old-fashioned anesthesia of this type would be Versed and fentanyl, right? And what's the problem with Versed and fentanyl?
Well, the problem is when you start combining, first they last a lot longer in your system, so the wake up time was slower.
Yeah, so it's a much longer half-life.
It requires really high doses to get the type of amnesia and hypnosis that we need for this tolerate this procedure.
So why would anyone use Versed and fentanyl over Propofol? I know the answer.
They don't have access to it, number one, and they're not certified to do it.
All right, so
Reduction, right? Factor reduction and all that
it's a lot cheaper to use Versed and fentanyl, right?
But it is a bad technique.
So what?
It's a bad technique because to be able to achieve your goals, you need to use a lot of medication.
It's dangerous.
Very
Standby laser. Yeah. All right, so yeah, I agree with you. Let's turn the suction off for a second. So we're pretty much done with the disc repair at this point, and I want to show you the nerve root. There's a little epidural vein that's bleeding. So I'm going to turn our irrigation back on and clear it. But you can see we had to take some bone spurs out too. The nerve root is right here, just to the north. And it's in a little bit of fat there. And that's the herniation, it's gone. So I feel good about it. Let's see what that is right there. Let me see the laser.
Yes, sir.
We're pretty much done. I'm just going to zap a little bit of this tissue right here. I don't even think that's it's probably just a little bit of residual disc herniation. Just have to be careful around the nerve root. All right. I feel pretty good. That's not compressing the root or anything. So we're good. We're done. Mission accomplished. And we're going to see this lady in recovery in about an hour, if you stay tuned. Right, Zach?
Yes, sir.
Without any technical issues with our hardware. Hopefully we fixed our broadcast device. But we're going to take the tube out. Luis is applying pressure to the paraspinous muscle. It was mostly medication that came out. Let's take a look. Come off for a second. Stay around. See how big the incision is here, Zach? Back on.
We can see it.
Back on. Back on. 3 minutes, okay?
Yes, sir.
You guys got this? Good job.
We got it, we got it.
Good job. Great job, everyone. Thank you. I'll head over and answer any questions that our audience may have. So go ahead and start typing your questions. Again, this was a left side Deuk laser disc repair here in Melbourne, Florida. We're about an hour from Orlando, Florida, if you're wondering. And if you want to come out and get your back or neck fixed and take your wife and kids or husband and kids or whatever it is you have and kids to Disney, and get your spine fixed at the same time. We have a lot of people who do that. Florida is a great place to visit. It's actually, thank you, the number one, great job, number one tourist destination in the world. There are 60 plus million visitors every year. So you'd write same. Procedure good. Disc herniation, bulge, facets, yeah. Good. Yes. None. EBL, we'll say, was 3 milliliters. And this was a left. L3, 4. DLDR. You got your discogram. There we go. Good. It's perfect. Thank you. How's it going? So what I was saying is you could do a little medical tourism. I mean, you know, typically with medical tourism, when you go places, there's none of the tourism part. But Orlando's got the best tourism in the world, right? It's the number one tourist destination in the world. So we do have the actual medical tourism. Maybe you can even call it surgical tourism. So we'll coin a new term today. Surgical tourism. Right here near Orlando, Florida. And by the way, we're in the Space Coast. The Space Coast of Florida is where NASA is, where all the satellites are launched, where the SpaceX rockets are launched. So it's a really neat place to visit. You have Port Canaveral with all the cruise ships. So come get your back or neck fixed and get on a cruise the next day. The recovery period for the surgery is 1 hour, and the next day you could go on a cruise or you could fly home. Or you can go to Disney. All right, talk to you soon. This is Dr. R. Deuk Machen. Okay, I'm back. This is Dr. R. Deuk Machen, and you've been watching us perform a Deuk laser disc repair on a patient who had a herniated disc at L3-4 on the left side with left leg pain, left-sided sciatica. And as we were talking about, I was educating you on the difference between compression versus chemical irritation. And it's important to understand that all herniated discs cause symptoms by either compression or chemical inflammation or irritation, okay? And so either compression or inflammation. I'm telling you about, in my experience, and all I do is treat patients with spine problems like herniated discs. In my vast experience of 20 years, I could tell you 95% of symptomatic disc herniations in the neck and back are due to chemical irritation or inflammation. So it's chemical irritation of the dura around the nerve root that's right there behind the herniation, or the dura that goes up around the brain. And the symptoms that patients have are due to the chemical irritation 95% of the time in my experience. Why is this important? Why am I talking about it? I'm talking about it because some of the people listening to me right now have gone to the doctor with back or neck pain they've had for a long time, and the doctor gets an MRI scan and they look at it and they say, you know what, there's really nothing here pinching a nerve. There's just some small disc herniations, or small disc bulges is what they call them, because a bulge is still a herniation, but it's just a contained herniation, which is really 99% of the time what we see, contained disc herniations. And the doctor is writing off the herniation, saying they're not the cause of the pain, when actually they are. And the reason they're making the mistake is that most doctors believe for a herniation to cause symptoms, the herniation has to be very large, and it has to be obviously crushing the nerve root. So if you're looking for that as a doctor who's treating patients with chronic back and neck pain and arm and leg symptoms, you're going to miss 99% of the patient's problem, because all you're looking for is the wrong thing. You understand? So if you're a farmer and you raise sheep, okay, and you have a flock of sheep, and you go out and check your sheep every day, and you notice that sheep are missing. So night comes and you tuck your flock away in the pastures, and the next day after night has come, you're missing 2 sheep. And then the next day you miss another sheep, and the next day you're missing another sheep. So you start to say, well, where are my sheep going? So you go look for them and you can't find them. So what you find, on the other hand, is blood, and you find evidence that the sheep was attacked and they were killed and then hauled off and eaten. But you have no clue what's doing it. So if you're a surgeon and you have patients with herniated discs and back pain, or herniated disc, neck pain and arm pain, or back and leg pain, as I said, and you're looking for a big disc herniation causing the symptom, that's the same situation as the farmer looking for a dinosaur that's eating their sheep, rather than a wolf, right, or a mountain lion, or something that makes more sense, something that's the real cause, something much more common. So much more common today would be a wolf or a coyote, right, or a mountain lion coming and eating the sheep, okay? What is extremely unlikely is a dinosaur coming and eating the sheep. So what I'm saying to you patients and you doctors out there that are listening is, based on my years of experience doing this, I'm certain of this fact, is that the vast majority of patients, 95% plus, that have back and leg pain or neck and arm pain, it's coming from that small disc bulge or disc herniation. And don't look for a large disc herniation, because you won't find it. The large disc herniations are extremely rare as a cause of symptoms, okay? And so if you want to know what's causing the back and leg pain or the neck and arm pain, it's going to be a small herniation. So when you patients go to your doctor and they get an MRI and they tell you, nope, there's nothing but small disc herniations here, you've just found the cause, most likely, of your back pain or neck pain. So don't believe your doctor when they tell you small disc bulges or herniations can't cause severe pain, because they do all the time. That's the main lesson here, okay? Why am I telling you this? Because you won't hear it from very many other people in the world. There's only a few of us that know this. There's only a few of us that understand it. When I say us, I mean us spine professionals, okay? For example, I'm not talking about just surgeons that know it. I mean, there are some chiropractors that understand this. There are some physiotherapists that understand it. There are some interventional pain management doctors that understand it. There are some orthopedics and some neurosurgeons, but not many. Very few understand that non-compressive disc herniations can actually cause severe pain down the leg or down the arm as though they were compressing the nerve root. Okay, so that's the important lesson. In other words, don't give up because you're told you've got small disc herniations. Don't stop searching and looking for the answer. You'll find it. And if you're not sure, come to Deuk Spine Institute. We will find it for you. All right, so that's my talk on the importance of small disc herniations in the neck and lower back as causing major symptoms for people needing surgery. This patient that you saw today, she had a medium-sized disc herniation on the left at L3-4. And she, though, had mostly chemical irritation, in my opinion, causing irritation of her left L3 nerve root. And that's what was causing her back and leg pain. We confirmed that with our discogram in the operating room. We did an evocative discogram, and she had severe pain in her back. It was her typical back pain she gets all the time. Okay, so we confirmed that we were in the right spot at the L3-4 disc. There was a giant tear. It was a grade 4 tear, and you could see all the dye leaking out very quickly through that massive tear in the annulus out into the epidural space around the nerve root. So I felt very confident that we were treating the culprit, the cause of her back and leg pain, that we discovered it and we were treating it. So I can tell you half the battle is discovering where people's pain comes from. And most of the time, at least 50% of the time, people that have chronic back pain or chronic neck pain, their pain's coming from more than one source, meaning more than one treatment. In other words, it could be the facet and the disc. Those are two completely separate treatments. The facet joint treatment is a rhizotomy with a needle, and the disc treatment is laser surgery to repair the disc that we do here, the Deuk laser disc repair. So you've really got to understand, as a healthcare professional treating patients with back pain or neck pain that's chronic, you've got to understand what are the potential causes of pain in that area. What joints, what muscles, what ligaments. So you have coccygeal ligament, SI joints, piriformis muscle, facet joint, the discs. Okay, those are all potential causes, fracture as well. So what you have to do as a healthcare provider is figure out what causes someone's pain. And a lot of time, if you do your job right, you're going to come to the conclusion their pain's coming from more than one place, at least 50% of the time. So you've got to treat those multiple sources of pain. Otherwise, the patient is still going to have pain if you only treat one of those sources. So it's important that you treat all the sources of pain. Treat all the sources of pain. Otherwise, the patient will still have pain. So it's very important, too, our strategy at Deuk Spine Institute here in Melbourne, Florida. At Deuk Spine Institute, we always try to treat whatever pain the patient has that's significant, that is least invasive first. So it's funny because the right thing to do for patients is to always do the least that you need to do to fix their problem. And what I mean by least is the least invasive and the least risky to the patient. So it turns out the least is also usually the most cost effective. So not only are you saving the patient and the whole healthcare system money, but you're also doing the safest procedure for them. So we almost always start treating our patients at Deuk Spine Institute with a needle procedure, usually a medial branch block, rhizotomy, or an SI joint injection. The point is we try to avoid putting our patients through surgery. So there's only a few things that need surgery. So we don't just jump to surgery. We always try conservative, non-operative treatments first. And you'd think that people would appreciate that, but sometimes some of our experience has been that some people feel like, well, why didn't you just do the surgery in the first place? Well, we didn't know you needed surgery in the first place. Yeah. Otherwise, you'd be a knife-happy surgeon if every patient that walked in the door, you just say, let's do surgery. It's the wrong thing for the patient because 90% of the time they don't need surgery. So that's right, you heard correctly. About 90% of our patients we fix without surgery. We fix them with physiotherapy and chiropractic massage and basically targeted injections or targeted lesions. That's with your needle procedures. It's interventional pain management. And of course, sometimes we give a muscle relaxer or anti-inflammatory orally. for a little while they heal. So only 9% of the patients that come to Duke Spine Institute end up needing surgery to solve their problem, which is why we always start with conservative treatment. But it's funny because some people don't get it, and they think, I don't know, they just they're upset because they feel we wasted time trying to fix them without surgery. But sorry, that's just the way it is. And by the way, as a patient, you always have a choice. You can always choose to say to the doctor, sorry, I don't want shots or therapy, I want surgery. And then if the doctor feels surgery is reasonable, it's going to help you, then the doctor could perform the surgery at that point. I think that's reasonable. Okay, I do have patients that come to me and say, Dr. Deuk, I've already had epidurals and facet blocks and everything. And I've tried pain pills, I've tried physiotherapy for 6 months. Honestly, doc, I just want the surgery. So if that's the case, and I feel that the surgery is going to help them based on their physical exam, then I move forward with surgery without doing additional conservative treatment. But the patient has to have already had some conservative treatment. All right. I'm going to go ahead and answer the questions that have popped up on the screen. I've talked for a few minutes, and I've given you all an opportunity to ask more questions. Again, for those of you who played this at Duke Spine Institute here in Melbourne, Florida. And the surgery went very well. You'll all be able to watch the patient in about 30 minutes, leave the facility. It takes an hour to recover from the surgery. It's outpatient. Everybody goes home. And if you're flying in from another country, which we have a lot of patients who fly in from other countries for the surgery or other states, you can go home the next day. So if your surgery is today on Tuesday, you can go home Wednesday and fly back or drive back, whichever you feel you need to do. People ask me when you can go back to work after Duke Laserdisc repair. You can go back to work as soon as the next day if you want to. I've had people go back to work the same day. I don't advocate that, but we have some very high functioning people that come here for surgery. One of them was the head coach of a basketball team who had a championship game the same day as his surgery. So he ended up coaching that game that night. But that's, everyone's different with respect to their work and when they want to go back and what restrictions they're going to have and whether the work will allow them to come back with restrictions. So you will have restrictions after the Duke Laserdisc repair. They're temporary, usually for 6 weeks to 3 months. And we discuss those restrictions with each of our patients. As long as you follow the restrictions, your herniation will not come back. I have patients now 13 years, 12 years, and out that have done fantastic without needing any additional treatment. So the recurrent disc herniation rate is 1%. That's 1 in 100 patients will have to have another surgery for a recurrent disc herniation with the Duke Laserdisc repair. 1%. That's the lowest reoperation rate of any surgery for the spine in the world. And remember, we've had 0 complications in 13 years. That's the lowest complication rate for any spine surgery in the world. And our success rate of getting rid of patient symptoms is 92.5%, and that's with 6 years follow-up on average. That's the highest success rate in the world. So when it comes to spine surgery, as a consumer, as a patient suffering with a herniated disc, the important questions to ask are, what's the success rate? In other words, how much of my symptoms are going to go away with the treatment? And the Duke Laserdisc repair has the highest success rate, hands down. The next thing you're going to want to know is, am I going to be worse? Are you going to hurt me with the surgery? Are you going to cause a complication? What's the chance of getting a complication and getting worse? The answer with the Duke Laserdisc repair is 0. Okay, to date, that's 13 years of doing the surgery. To date, we've had 0 complications, 0 infections, 0 nerve damage, 0 CSF leak, 0 pneumonia, 0 whatever you want to, any kind of post-operative spine complication. We've had 0. So there is no other surgery in the world that has 0 complications after 13 years and 900 surgeries. But the Duke Laserdisc repair, that's how safe it is. And then you want to know, when can I get back to work? And when can I get back to my activities that I like to do? With the Duke Laserdisc repair, it's very quick. It's the shortest of any procedure. So you're looking at, depending on what it is you want to do, a few days to a few months. Okay? As far as cost goes, the Deuk laser disc repair is much less expensive than an artificial disc or a fusion. And those are the alternative type procedures, or a microdiscectomy, for example. So it runs about the same price as a microdiscectomy, but microdiscectomies, they remove the bone from your spine and destabilize it, your spine. So you'll need a fusion later. Okay? They won't tell you that. They'll tell you it's not true, but it is 100% true. See it all the time. Not in my patients, but in other surgeons' patients. Microdiscectomies, laminectomies frequently result in additional surgery being needed, like multiple surgeries. We have people who've had surgery with a few of the surgeons locally. I won't mention any names, but they've had 5, 6, 7, 8 surgeries. I had people who have come to me and called me and asked for help that have had 10, 11, 12 spine surgeries. It's absolutely ridiculous to have that many surgeries. If you're having more than 2 surgeries on your spine, there's a huge problem. All right? And you need to literally get a second opinion quickly. At Deuk Spine Institute, we'd be happy to do that for you. When I say surgery, I'm not talking about an epidural injection. I'm not talking about a needle procedure. I'm talking about real surgery where they cut your skin open and do things in there. Okay? So there's no 99% of my patients have 1 surgery. 1. Only about 1% of my patients need more than 1 surgery because they injured another part of their spine above where I operated, or they injured the same area. So the reoperation rate at Deuk Spine Institute is about 1 to 2%. The reoperation rate nationally on average is about 10 to 20%, 15% average. But there are some places you could go for your back surgery and it's a 50% reoperation rate. Honestly, those places should be shut down, but they don't. They don't shut them down. There's no government agency that shuts them down. There's no insurance company that shuts them down. So it's incumbent upon you, the consumer, to shop around and find the best place for you to get your back or neck fixed for a herniated disc. All right, I'll take the questions, Zach.
The first one is, when you say 92.5% relief, do you mean that your patients have an average of 92% relief, or that 92% of your patients have relief?
Oh, all right. So one of our viewers asked a very astute question. They asked, when you say 92.5% relief of back pain or neck pain for the Deuk laser disc repair, do you mean that 92.5% of your patients have relief? Or do you mean that your patients on average have 92.5% relief? It's actually the latter answer, that my patients on average have 92.5% relief. So how do we calculate this number? It's a very important number. So here's how we did it. We did it honestly and truthfully. So when patients have surgery and then we follow up with them after surgery, which is usually in the clinic the next day or a few weeks later or a year later or so, we literally will sit down with the patient and say, do you remember the pain you had before surgery in your back? Yes. All right. That pain you had before surgery, how much of that pain is gone? And the patient will tell us the percentage. So generally the patients will say 80%, 90%, 100%. It's gone. I don't have that pain anymore. That's 100%. So we ask that question of every one of our laser surgery patients after surgery, and we ask them, how much of your lower back pain that you had before surgery is gone? How much of your leg pain that you had before surgery, or numbness or tingling or weakness, how much of that is gone after surgery? So the patients give us a percentage. We write those numbers down in the medical record, and when we do our research, I have a research associate who comes in, goes through all the medical records of all the laser patients, pulls those charts, opens the page to the clinical note, and looks at the answer that the patient gave, percentage-wise. Then tallies up all those percentages, divides it by the number of patients, and you get an average amount of pain relief for everybody. That's how the number's calculated. The important things to know here is that Number one, the patient gives us that percentage. It's not a percentage we pick, it's what they pick. Number two, the medical assistants are the ones who collect that information about the relief that the patient gets from the patient. So the surgeon has nothing to do with it. And then the medical research assistant who looks at the numbers is, of course, just a research assistant. They're not the surgeon. And so their job is just to take all those numbers and run a simple math calculation to find the average pain relief. So the average pain relief for the Deuk laser disc repair is a patient outcome measure that's a patient reported measure by the patient to the medical assistants in clinic. I don't even see these patients, by the way. So if you come to Duke Spine Institute, have a Deuk laser disc repair, when you come in and get seen afterwards, I usually will not see you unless you're having a problem. I'm available to see everybody, and if patients want to see me, I'm there. I'm happy to see them. But generally for uncomplicated patients that have had treatment, they don't need to see me, so they end up seeing one of our other staff physicians, and they collect that data. In other words, that data is not biased in any way. It's collected from the patient by unbiased staff, basically. So great question about the data. Very important that you understand how data is collected by whoever's reporting information to you. Same thing with the complications. Obviously we follow all of our patients and look to see if they've had complications as a result of the surgery. And we've had, as I said, 0 complications with the Deuk laser disc repair. Intraoperative complications, I don't know of any postoperative complications. Now, when patients have pain from other areas in their back or neck after surgery, let's say we fix a herniated disc with the laser surgery, but now they develop sacroiliac joint pain. That's not a complication. That's basically another area of pain that they could be having, because people with chronic back pain, what happens is they end up standing and walking and changing the way they do. They stand and walk improperly. Maybe they favor one side, so they're walking favoring one side, so their weight is distributed improperly through their pelvic area, through their hips and knees. Long story short is that if you get a herniated disc and it causes back pain, and it only causes back pain when you lean to the right, then you're going to lean to the left to avoid the pain. So leaning to the left, though, causes sacroiliac joint pain and inflammation and facet pain. So basically what I'm getting at is it's like a cascade effect. It's a situation where you injure one part of your back and it creates pain and aches in other parts, muscles and joints, because of the way you're walking and standing. We see this all the time. It's very common. So fixing a herniated disc doesn't fix necessarily all the back pain, which is why we try to fix back pain without surgery first, because all those other things don't require surgery, like SI joint dysfunction can be fixed with injections and therapy and gait training. So it's important that patients understand that we will fix the disc herniation if that's the core cause of their pain, but they're still going to have deconditioned muscles that, what's called a chronic lumbosacral strain, where they're going to need to rehabilitate those muscles over the next 3 months after their surgery. But now they can because their back pain's better. So it's still a complex issue, but it's simple if you just understand these issues and how they relate to each other. Long story short, those numbers are derived through proper data acquisition of getting a patient-reported number by a non-biased employee, which is the MA. And then that data is reviewed and analyzed and calculated and run through statistical analysis by a research assistant. So that's how we get the number. But it's on average, take any patient having a Deuk laser disc repair, their chance of having the percentage of pain relief that we expect them to have on average is 92.5. So the lowest I've ever seen is 50% improvement. Okay? When we look at the numbers, 50% improvement in their preoperative pain is the lowest I've ever seen. And about a third of the patients have 100% improvement. 1/3. All right, what's the next question?
He says, my inflammatory markers don't show any elevation, so I'm wondering what could possibly be causing my back pain to be so severe.
Well, so somebody's saying I have severe back pain, but my inflammatory markers are not elevated. So the answer to your question, what's causing your back pain, if you don't have a fracture, well, even if you do, I can tell you right now, your back pain is due to inflammation, 100%. So you're asking me, well, my inflammatory markers are not elevated, because they're not going to be elevated. Inflammatory markers don't get elevated for inflammation and annular tear. You'll never see elevated inflammatory markers. Our tests are not sensitive enough. And remember, that's such a small part of your body. It's a tiny little area that's inflamed. So you're not going to see an elevation in sedimentation rate or C-reactive protein. You'd have to have a lot of inflammation, like an infection or something, or massive inflammation to have elevation of those markers, not just one little tear in your disc. So the fact that inflammatory markers, I believe you're talking about C-reactive protein, ESR, but if there's other markers I'm unaware of, you can mention them and I could look into it. But that doesn't surprise me one bit. Your pain is still caused by inflammation. All right, that was our last question, and I've enjoyed our time together. This is Dr. Ara Deuk-Majan, the founder of Deuk Spine Institute. We just finished surgery. We're going to go check on our patient. She should be ready to go in about 20 minutes. So we're going to do a live stream, if she allows us to, from the recovery area as she goes home. And I want to apologize to everyone that watched the last live stream. We had some technical difficulties. We bought this special box. What's it called? It's called the streaming box. It allows us to stream video live from the recovery area. Anyway, that box is not working. So if anyone wants to donate a new one for us, they can. But otherwise, we think we figured out with some software updates, maybe that was the problem. So we're going to try to do a live stream today from the recovery area in about 20 minutes if our patient allows us to. Again, we respect patient privacy for all of our patients. All of our patients that you watch live streams, they've written and signed consent to allow us to stream live. We don't disclose their name or any information about them as an individual. However, we do stream live so we could teach people and educate the public. As far as recovery room videos, it's different because you can actually see their face. You can see who they are. And so that's definitely protected. And they have to give us permission for that. So we do get permission prior to doing any kind of stream from the patient in the recovery area. But some patients don't want it, and we don't do it. We only do it if the patients give us permission. So we'll ask and see what she says. And if she says yes, then we'll be streaming live in 20 minutes. So you can see her leave the facility. Typical recovery for Deuk laser disc repair is just under an hour when people come out of the operating room to when they leave the facility in their car. Everybody goes home. We don't have any hospital transfers. We haven't had a hospital transfer in 13 years. So all of our patients do fantastic and end up going home or to their hotel until they're ready to leave the next day or the day after. Or go to Disneyland. Enjoy some time with their family. Thanks for watching. We'll be back with you soon.